everyone, and welcome to Treating Difficult Bleeds, the first in a new series of webinars for individuals, families, and caregivers affected by hemophilia A and B and inhibitors. These activities are designed to enhance and expand on the education provided at the National Hemophilia Foundation's Inhibitor Education Summits. This webinar series is supported by an educational grant from Novo Nordisk. This evening's program features 3 hematology professionals with a combined 60 years of experience caring for patients with bleeding disorders. First will be Jennifer Moss, a pediatric nurse practitioner at the Indiana Hemophilia and Thrombosis Center in Indianapolis. Jennifer will talk about the early identification of bleeding episodes, joint disease, and the warning signs of a serious bleed. She will be followed by Dr. Michael Torrentino, hematologist and medical director of the Bleeding and Clotting Disorders Institute of Peoria, Illinois. Dr. Torrentino will discuss the challenges inherent in the treatment of bleeding in patients with inhibitors. The third portion of this evening's presentation will be given by Ruth Mulvaney, Doctor of Physical Therapy at the University of Tennessee Health Science Center in Memphis. Dr. Mulvaney will describe techniques for maintaining healthy joints. Our program will conclude with a question and answer segment. If you would like to ask a question during the presentation, you may do so by going to the chat pod located in the lower left corner of your screen. Type your question and press the send button. However, please note that your question will be addressed during the question and answer session at the end of the presentation. We may not get to all of your questions, and similar questions may be responded. There are no handouts for this presentation. However, a recording of this webinar will be available shortly on the National Hemophilia Foundation website at www.hemophilia.org. Before the presentation begins, we would like to start with 2 quick polling questions to get a better understanding of all the people who are participating this evening. Shortly, you'll see our first polling question appear on your screen. Have you ever attended an inhibitor education summit? Please respond yes if you have, no if you have not. We'll pause a few moments for you to answer. Thank you for your responses, and we see that 33% yes have and 66% have not. We'll continue now with our second question. What best describes the bleeding disorder status for the person in your family? Option 1, unaffected bleeding disorder. Option 2, person with hemophilia A with inhibitor. Option 3, person with hemophilia B with inhibitor. Option 4, carrier, confirmed or possible. Or option 5, person with other bleeding disorder without inhibitor. Thank you for your responses. We'll share those responses for a moment. Thank you, everyone, for participating in those short questions. It is now, without further ado, that we will begin our program. I will turn things over to our first speaker, Jennifer Moss. Jennifer, welcome. Please go ahead.
Thank you, and welcome everyone to the seminar today. We are glad you're taking time out of your busy day to sit and listen to us present. This first part of the presentation, or section 1, will be review of bleeding episodes and joint disease. Section 2 of the presentation, I will turn it over to Dr. Tarantino to discuss treatment options and also highlight treatment considerations for persons with inhibitors. And then Section 3 will be followed by, or Section 2 will be followed by Ruth Mulvaney talking about review of interventions to lessen the impact of joint disease on activities of daily living. So let's just go into my section. And my section is going to be broken down into the progression of joint disease, how joint disease is evaluated in the clinical setting, and then also a discussion of life and limb-threatening bleeding. When we think of musculoskeletal complications, especially in severe hemophilia, we know that 80% of bleeding episodes occur mostly in joints. If in patients who are not on regular treatment, those bleeding episodes can occur approximately 30 times per year. And what we know is that in the over 30 years of age, most of those bleeding episodes probably occur in the elbows and the knees. In patients under 30 years of age, looking at very active children or young adults, what we find in the clinical setting is a lot of bleeding, joint bleeding that occurs in the ankles. And it could be despite regular prophylaxis. And often, especially in the pediatric population, it's related to high activity levels. Joint bleeding, often the cause is unknown, or it may be related to trauma, and it usually affects one joint at a time. The next slide reviews common sites of bleeding, joint bleeding. So 80% of joint bleeding occurs in the ankles, knees, and the elbows. And why is that? Those joints are different. They're hinge joints. And because of this hinge activity, it's sometimes easier to pinch off the small blood vessels in the joints, causing bleeding episodes. Less common sites of bleeding are the joints that include the hips and the shoulders and the wrists. So if you're a patient with joint disease, most times it's your bleeding episodes occur more frequently in the ankles, the knees, or the elbows. So I think it's often hard for a patient, especially somebody who's just learning about bleeding disorders, to speak the same language. And so what I'd like to do throughout our next couple slides is really kind of break down those big words you may be hearing in clinic to let you know what they mean and what we're talking about. Hemarthrosis may be a common term you hear. Heme means blood, and arthrosis is an area where two bones meet for the purpose of moving, the motion. And so if you combine those, hemarthrosis is a term that we use for joint bleed. What are the symptoms of a hemarthrosis? Patients often complain of pain and discomfort early on, before maybe any visible signs of swelling or joint changes. Later, as the blood or the bleeding episode continues and the blood swells or collects in that joint, the joint swells, and what we may find is that it's more comfortable to bend that joint because that helps decrease pain. So early you may not see any changes. Later changes, it's usually a swollen joint, and often the joint then is flexed because it's a position of comfort. Joint bleeding can occur suddenly, and we call that acute hemarthrosis. So anytime there's the word acute, it just means a sudden onset. It hasn't been going on for days and days or months. It really has just happened. In joint bleeding, acute hemarthrosis, what we often find is that symptoms develop over a few hours. You may feel some pain, you may feel some discomfort, but it doesn't take long for those symptoms to progress. A giving factor reduces pain rapidly because what you're doing is you're stopping the bleeding episode. But depending on the amount of blood that has collected in that joint space, it may be that there was a delay from when the bleed started to when the treatment occurred. The swelling may continue for some time, over several days, but it's directly related to the amount of blood that's in that joint and when treatment was initiated. Often joints continue to have repeated bleeding episodes, and we may call those subacute hemarthrosis or something that's a little more kind of long and lingering. It's not something that just happened. These joints then become a target joint. So what's the definition of a target joint? The official definition has never been decided because nobody can agree on exactly what they want it to be. There's some consensus or some general agreement in the medical community. If in Canada they look at a target joint as 3 bleeds in a single joint on 3 consecutive months. In the United States, many of us think of it more over a 6-month period. So at least 4 bleeding episodes in the same joint in a 6-month period. So if you're experiencing that in a joint, the same joint, that's considered then a target joint, and that may be some terms that we're using for that. Changes are detectable in the joint between bleeding episodes. So what we're seeing is the joint is having some damage, not only from the bleed, but damage that is evident in between. The next slide looks at the term hemophilic arthropathy. So what does that translate into as we're all trying to speak the same language? Hemophilic is related to bleeding, which is related to your hemophilia. And anytime you hear the word arthropathy, it's a disease of the joint. So you can have arthropathy in any joint, and it's something's wrong with the joint, things aren't normal. And it's usually because of the bleeding, the repeated bleeding episodes. So what changes might we see as you continue to have bleeding in the same joint? The fluid in the joint becomes thick, and you may find that the fluid's swollen even when somebody's not bleeding. So in a joint that has some hemophilic arthropathy, it may be chronically swollen for months, for even longer. Over time in that joint, the bones tend to get bigger. And a bigger bone then limits the amount of movement that you have in that joint, because bones are really made to fit together nicely. And once you have one bone enlarged, it really impacts the ability of movement into that joint. Over time, the blood that's present in the changes and the swelling and inflammation in the joint can cause other losses like the cartilage, and bones can flatten. And at this point, the joint becomes very unstable and often painful. So how often should we, if you have hemophilia, severe hemophilia, how often do they recommend evaluation of your joint? In a growing child, we would definitely recommend every 6 months to being seen by your medical provider at your treatment center, so you can have a good discussion about what has happened in the past 6 months, where, are there changes you're concerned about, and really just to have some ongoing longitudinal care. In adults, the recommendations are at least every year. So, we probably, depending on your situation, in the case of somebody with an inhibitor, you may be seen more often than once a year, but at least once a year is the minimum. And how do we remember what your joints are looking like from year to year and from visit to visit? There's different scales that are available. There's just one scale that I'm mentioning, the Gilbert scale. And what that is it's a way for me to look at your joint, talk about how much pain you're having, how much bleeding, how often it's occurring. Is your joint stable? Is it moving? Do you have good movement in it? Is it swollen? What do the muscles look like around the joint? And really to give you a score, so when you come back in 6 months or a year, I can see, are you still the same, or have any of those symptoms worsened? And it really gives us an ability to kind of just track your joint over time. The Hemophilia Joint Health Score is another one that may be used in clinical practice. And the advantage to this is it's really better in children in picking up some maybe early joint changes. We may also, in a joint that we're worried about, start doing some imaging testing. You can only see so much with the human eye, so we may have to look inside the joint. So the next couple of slides are really just going to talk about what kind of imaging you may be, that may be requested of you. So X-ray is a common test. The pros of an X-ray is it's easy to obtain, it's inexpensive, and it detects bony changes, it detects swelling. But the cons are it really doesn't evaluate soft tissue, the tissue around your joints, the tendons, the ligaments, and it's not sensitive to early joint changes. It's going to tell you if you have severe bone disease, but it's not going to tell you if you just have some changes within that joint. The next test that I'll talk about is ultrasound. This is becoming more and more discussed. It's the pros to an ultrasound is it's inexpensive and it's non-invasive. It helps us evaluate soft tissue. Is it inflamed? Do you have more joint fluid than you did the last time you were in? And it really, the beauty of this one is it just allows for some just fine-tuning of current treatment. If you come in and say that you had increased bleeding and we do an ultrasound and it shows some more swelling than the last time, that may be a reason for us to make a change in your treatment. It's easy to use on children. It doesn't hurt. But the cons are it really doesn't give us a good picture of what's going on in the bones and the cartilage of a joint. MRI is really what we call the gold standard to identifying early joint disease. It looks at multi-tissue imaging. So it looks at your bones, your ligaments, your tendons. It may really detect some small changes that are going on in the joint that clinically, from just looking at your joint in clinic, we may not be able to detect. The cons of the MRI is that it's costly. It's not so easy to get it done. Because it has to be scheduled. A lot of times it has to be pre-certified. It's time consuming. You have to hold your joint in a frozen state for a period of time, an hour or so. And some people with advanced joint disease, it's not as comfortable for them to do that. If it's a young child, it may require that they're sedated. So this is really, though, the optimal test for looking at joints, but it is the hardest to get done. Often patients that have joint disease and joint pain, they say, am I having a bleed if this is a bad joint, or is it just arthritis that's from my joint disease? Bleeding, a way to kind of start hashing out which one it is. Bleeding is usually injury related. It's sudden onset. A lot of times people talk about waking with pain in the morning, pain and stiffness. In the case of bleeding, unless you started bleeding the night before, morning pain is probably not a bleed. It's probably arthritis. A bleeding episode will get better with infusion. If it's arthritic pain, what we find is it's worse in the morning because you're stiff because you've slept all night. It improves as the day gets better, maybe without any kind of treatment. Weather changes may impact it, and I put a question mark there because there's not a lot of hard science that says weather changes can make a joint hurt, but I think that a lot of patients will definitely say that that does. Maybe are you in pain because you sat for a long time or you held that joint in the same position for a long time. And definitely arthritic pain may not get better with one infusion. So the last part of my section is we're just going to go over some life and limb-threatening bleeding. So bleeds that are much more serious that we need to worry about. Bleeding in the head, which is inside the skull, not a bump on your forehead. It's the bleeding that's inside the head, the bone. Can be from an injury, a car accident. We've had people that have hit their head on the windshield and then bled inside their head. Symptoms are not always evident until there's blood accumulation in that area. So if you're bleeding inside your skull, you may not have symptoms until that blood collection has become big enough that it's causing pressure. So it could be several hours. It could be the following day. You are going to have progressive symptoms, though, probably nausea, headache, and changes over time. Other life-threatening bleeding can occur in the throat. We've seen it from trauma, after dental work. There's a whole slew of other causes. The problems with the throat is that swelling from blood fills the tissue, and that closes the airway. So that can definitely be life-threatening. Or you can have patients that have a tear in the tissue in the throat that causes blood loss. That's a little more obvious because you start vomiting blood. All of these that I'm mentioning are definitely emergent situations, and you need to be in close contact with your treatment center. The next, life-threatening bleeding, can occur in the abdomen, so in any organs. It can be from trauma. It can be the result of surgery, ulcers. You may have abdominal pain and swelling. You may have vomiting related to blockage. Again, this is a life-threatening situation. You need to be contacting your treatment center. Limb-threatening bleeding is really looking at, is your limb at risk for not being able to be used? And we'll talk about that as we move forward. Why does that occur? Bleeding into the large muscles in your limbs, your arms, your legs, especially your calf, your forearm, your thigh, your gluteal region, those muscles have expandable space within them. So it can collect a large amount of blood. And you may not have as many clinical signs until that blood volume in that muscle is so high. The problem that occurs when you bleed into these areas is that you can have nerve compression and cause nerve death. Initial symptoms of that are numbness and tingling. So anytime you have a bleeding episode related to some numbness and tingling, really that's a bleed you want to become aggressive with. These bleeds, because you can lose a large amount of blood in a small space or in your big muscle group, can also cause a blood volume issue or what we might call severe anemia. Okay, well thank you everyone, and I've completed section 1, and I'm going to turn it over to Dr. Tarantino, and he can talk about treatment of bleeding episodes and especially the challenges that occur in patients with inhibitors.
Great. Thank you very much, Jennifer, for that wonderful review. So I will talk to you, welcome everyone as well. Thank you for coming out on this evening to learn about inhibitors and how to manage them. So my section is on the challenges to treating and preventing bleeding in persons with hemophilia and an inhibitor. Okay, so just a word about the inhibitor, which, as you know, is an immunity against the factor that we give someone that has hemophilia. So factor is the mainstay of treatment, but for persons with severe hemophilia or even moderate hemophilia and occasionally mild hemophilia, the factor we give sometimes is recognized by the body as a foreign protein, and immunity is made against it that kind of wipes out the effect of the factor. So even though we rely on the factor to prevent and stop bleeding, if an inhibitor takes away that effect, then we're left with this vulnerability to bleeding that can go uncontrolled or more frequent bleeding that can happen. So I'm often asked, does an inhibitor cause more bleeding to occur? So the inhibitor not only neutralizes or wipes out the infused factor, that's factor 8 or factor 9, but also if a person makes a small amount of factor 8 or factor 9, like in moderate hemophilia or mild hemophilia, that may also get wiped out as well by the inhibitor. So it can create a situation where no factor is active, even the infused factor. So during the period of time from the beginning of the inhibitor, once it first develops, and the identification of it, so realizing that you have it, bleeding may appear more difficult to control and may occur more frequently. So the inhibitor doesn't cause the bleeding, but it leaves the person more vulnerable to bleeding that may occur with, say, exercise or trauma. Prophylaxis, being the attempt to prevent bleeding, may be ineffective or less effective, and that's how sometimes we discover an inhibitor is there. So especially in younger kids that are on prophylactic regimens of factor infusion, typically without an inhibitor present, that markedly reduces bleeding. But if an inhibitor develops, that prophylaxis may be ineffective and bleeding may occur as though the prophylaxis weren't even being done. So treating bleeding when factor 8 or factor 9 no longer works, what do we do? Well, we know that factor 8 or factor 9 both together help to activate factor 10 in the process of making a blood clot. Now, don't get caught up in the complexity of this slide, but just sort of visualize it from top to bottom, from the two arms of that Y shape. That's the beginning of making a clot, and the bottom of that Y, or the tail of the Y, is the end, or the process of having the clot made. Okay, so one of the steps in that process is making active factor 10. And people with hemophilia A or B have enough factor 10 to be activated. They just can't make it active. So persons with hemophilia need to find some way, another way other than via factor 8 or factor 9 to activate factor 10. So we do that by what we call bypassing factor 8 or factor 9. So bypassing factor 8 or factor 9, we do that with other products besides factor 8 concentrate or factor 9 concentrate. We have this group of concentrates called prothrombin complex concentrates, or PCCs. Now, for the longest time, and actually at least a couple decades, we've had these PCCs available. And really, they were really only agents used by people with hemophilia until very recently. And we've recently discovered that using PCCs is a good way to reverse blood thinners that other people with clotting disorders may take. So we're hearing a lot about PCCs in the medical arenas, but a lot of that chatter is not about hemophilia. It's about reversing blood thinners, which indirectly may be a good thing for us because more companies may be interested in developing PCCs that we could potentially use for folks with hemophilia. So PCCs are concentrates that contain prothrombin, which is our big clot-making enzyme, some factor 9, and some factor 10. So there's that factor 10 I mentioned that allows us to bypass the need for factor 8 or factor 9. Some of the three-factor PCCs also have factor 7, but all of the so-called four-factor PCCs contain factor 2, which is prothrombin, factor 7, factor 9, and 10. You may have heard of the term activated PCC. So in activated PCCs, and the only one that's on the market now is listed on the slide there. It's called FIBA. So in the test tube or in the manufacturing of the PCC, the activation of the components, mainly factor 7 and factor 10 occurs. Now some people think that the activated PCC works a little better to stop bleeding in someone with an inhibitor than a non-activated PCC, but honestly that really hasn't been proven. So this is just a list, just to give you an idea of how many products are out there on the market. A couple of them are only approved in Europe. A couple of them are no longer marketed now, but have been licensed in the United States for a long time. So you can see there's several choices out there, and these are all what are termed non-activated PCCs. Well, there's another way to bypass the need for factor 8 and factor 9 and make active factor 10, and that's by using factor 7. So that is depicted on sort of the right side of the upper arm of this Y-shaped coagulation pathway. So you know that many of you are probably familiar with recombinant factor 7. There's one product in the United States that's on the market right now. And factor 7 is very effective in activating factor 10 to bypass the need for factor 8 or factor 9. It must be a hot topic out there for manufacturing companies because there are several in development right now. Some of them are similar to what's already on the market. Some of the ones in development are being designed to last longer in the bloodstream, and some are designed to be more potent or be more strong in activating factor 10 to help people with inhibitor produce a good blood clot. Okay, so I just wanted to show you that there are recommendations for how much to give for a particular situation when it comes to bypassing factor 8 or factor 9. So here's just an example of dosing recommendations for FIBA. So you can see that for different types of bleeding, we use different amounts. Obviously, as Jennifer mentioned, the more serious the bleed, the more attention and the more aggressive we have to be with treating the bleeding. And similarly, there's dosing recommendations for factor 7 as well. And likewise, the more severe we think the bleeding is, the more aggressive and the higher the dose and the more doses we give to take care of that bleed. Both products, either the PCC or recombinant factor 7, have dosing recommendations too for surgery. And actually, some of this was for the recombinant factor 7 was very nicely worked out at Jennifer Ma's treatment center with Dr. Shapiro years ago. So we have a fairly standard dosing recommendation for recombinant factor 7 for persons with inhibitors that are going through either minor or major surgery. So you might ask, is one better than the other? Is a PCC better than recombinant factor 7 or vice versa? So we only have one study that's been published that really prospectively compared the two. Now, I don't want to bore you with the complexity of this graph, but in general, if you just sort of step back and look at it as maybe as a work of art, you can see that the effectiveness of treating the bleed, a bleed in persons with hemophilia and an inhibitor with FIBA, which is the PCC, or with Novo-7, which is the recombinant factor 7, looks about the same. And the graphs as you move from left to right are the effectiveness over time from the time of the first infusion to 48 hours later. And then the different fillings in the graphs have to do with how good it was at treating the bleed. So it looks very similar. Some people might argue that in the first 12 hours or so that maybe FIBA did a little bit better, but I think in general in the community among treaters we think that they work about the same. Now that's not to say that they work the same in every person, because as you know, everyone's an individual, and some patients will say, well, I really have better success with FIBA, or they may say, I have better success with Novo-7. Some of our folks have even told us with some bleeds that factor 7 works better, other bleeds FIBA works better. So I think we have to consider both agents as important factors to use for folks with hemophilia and an inhibitor, and be sure that we have both available for all of our patients. Well, I'm going to switch to talk about preventing bleeding now before I turn it over to Dr. Malvani. Preventing bleeding really involves more than just factor, right? It sometimes, unfortunately, involves a lifestyle change. Those of you in the audience that have hemophilia, or those of you that take care of folks with hemophilia, you know that certain activities are more risky at causing bleeds than others. And unfortunately, some things just have to be sort of taken off the table as, you know, activities that we recommend. So contact sports, of course, we usually steer guys with hemophilia away from contact sports. But other activities that don't seem so risky that way, really we have to sort of look at the person individually and say, you know, have you experienced bleeds while or after you played golf or jogged around the block, etc. So a real close look at the lifestyle is very important. Targeting a healthy BMI, that's body mass index, and that's another way of saying, you know, be as fit as you can be and avoid being excessively overweight, because that can contribute to, you know, having bleeding, especially in the joints that bear most of that weight, like your knees and ankles. And then, of course, this is a no-brainer. Avoid foods or medications that increase bleeding. And particularly, the medications would be pain medications in the non-steroidal anti-inflammatory class, like aspirin or ibuprofen. We don't have many foods on the do not eat list, but certain ones, like garlic, for example, taken in excess can thin your blood a little bit, and that could be associated with more bleeding. And then preventing bleeding does, of course, involve considering prophylactic dosing of one of those bypassing agents that I mentioned. Okay, so that's kind of a common sense approach, but what do we know at sort of a higher level, and what's recommended by some of our advocacy groups for folks with hemophilia? We know that prophylaxis can prevent joint hemorrhage and subsequent arthropathy, target joints, and disability. So that was nicely shown in a couple of studies here in the United States and in Italy that showed that prophylaxis markedly decreased the number of bleeding episodes. We have some more recent studies that have shown the same, that what we have shown in children, we've shown also in adults as well. So therefore, some major advisory groups like MASAC, which is the Medical and Scientific Advisory Council of the National Hemophilia Foundation, the World Federation of Hemophilia, and the World Health Organization recognize that prophylaxis is optimal therapy for persons with severe hemophilia without inhibitors, and we translate that too now, and I'll show you some evidence that supports that for folks with hemophilia and inhibitors. We know that patients with inhibitors are at increased risk for difficult to control bleeding and its complications. Therefore, prevention or reduction is of critical importance. And I'll show you a brief slide that prophylactic treatment may also improve a person's health-related quality of life and even help with pain management. So I'm going to briefly describe two studies for you. They're both three studies, actually. Two of them are illustrated on this slide. And again, don't get caught up in too much in the arrows and such, but know that this is just the design of the studies, moving from left to right on the top and the bottom. One study was called ProFiba, which was a study looking at how well we could prevent bleeds in patients with hemophilia and inhibitors using FIBA. So the patients that entered this study either started with an on-demand regimen, meaning they waited for bleeds to happen before they treated them with FIBA, or they started with a prophylaxis regimen, meaning on 3 days a week, they gave themselves a dose of FIBA to prevent bleeding, and then after 6 months, they had a period of time where they just did on-demand treatment, and then they were randomized again to either the on-demand type treatment or the prophylaxis treatment. So everyone that entered the study had a 6-month period where they just treated bleeds as they occurred, and a 6-month period where they prevented bleeding with prophylaxis. Another study called the PROOF study that was done in Europe just randomized a group of patients either to receive on-demand treatment for a year or prophylaxis for a year. Okay, so that's the setup, and I'll show you now the results of those studies. And as you might expect, in the ProFiba study, when compared with the on-demand treatment, prophylaxis on 3 non-consecutive days during the week reduced all bleeding substantially by 62%, reduced joint bleeding by almost the same amount, 61%. And remember what Jennifer told us, that most of the bleeds that happen in guys with hemophilia happen in the joints. And in those target joints, the reduction of bleeding was 72%. So that was amazing. And we considered that a landmark study and discovery that prophylaxis with FIBA during the time when a person has an inhibitor was very effective at preventing bleeding. And very similarly, we saw similar, if not better, reductions in the proof study where, remember, some patients received the on-demand treatment for a year, some received prophylaxis for a year. So very effective at reducing bleeding. Now, a few years earlier, we had a similar type look at recombinant factor 7 to see if once-a-day treatment with either 90 micrograms per kilogram once a day or 270 micrograms per kilogram once a day could reduce bleeding in a period that was called pre-prophylaxis, so they were just waiting for bleeds to happen and then treating them, a prophylaxis period that you see in the middle two chart graphs there, and a post-prophylaxis period. And remember now in the gray bars, that's the 90 mics per kilogram per day, and the white bars is the higher dose of 270. So during prophylaxis, the bleeding decreased by 45 to 59%, depending on what dose was given. So another substantial decrease in the amount of bleeding with prophylaxis. So I think these three studies together really nicely illustrate that bleeding frequency could be reduced quite a bit with prophylaxis if a person has hemophilia and an inhibitor. Okay, what about quality of life? So this was taken from information from that ProFIBA study, and each person that participated filled out questionnaires related to how comfortable or uncomfortable their life was. And they used standard validated quality of life questionnaires. And as you can see, at the beginning of the study in the dark bars, the 6-month time period in the darker gray bar, and the 12-month time period in the light gray bar, patients with prophylaxis had a better quality of life score. So in these graphs here, the higher the score, the better the quality of life compared to the patients that treated on demand. And then moving over to the graph on the right of this slide, this had to do with the person's perception of their pain at the beginning, middle, and end of the study. And again, the study looked at the patients who received FIBA prophylactically comparing to the patients that received FIBA on demand. And here, the lower the score, the better, meaning the higher the score, the more pain that the person had at the time. And as you can see with prophylaxis, there was a marked reduction in the amount of pain that the person was perceiving. And these are averages in these graphs. So one sort of side note about pain is that one very effective way to avoid pain or to reduce pain is not to have bleeding, especially repeated bleeding in the same joint. Okay, so just to wrap it up before I turn it over to Dr. Mulvaney, the pros and cons of PCCs and factor 7 that are used to bypass inhibitors to factor 8 or factor 9. We know that for both, we see hemostasis or control of bleeding or prevention of bleeding for the grand majority of patients. And for both, we have experience in surgery for persons with hemophilia and inhibitors. And we know now that prophylaxis reduces joint bleeding, target joint bleeding, and overall bleeding. And that's true for prophylaxis with both factor 7 and the PCC FIBA. One of the shortcomings, though, is the short half-life of NovoSeven. And as you may have gathered from one of the slides, the lower dose, 1 time a day of NovoSeven, gave less good results with preventing and reducing bleeding than the higher dose. So that's why some manufacturers are looking at developing longer-acting versions of recombinant factor 7. So all of the PCCs on the market right now are derived from plasma. And we know that plasma-derived products now have a long track record of good safety, but still I think many people prefer to have synthetic or recombinant factor. So as of today, we don't have a synthetic version of the PCCs, either activated or non-activated. And one shortcoming that we realize as treaters is there's no reliable laboratory test to monitor how well we're doing with the factor to treat or prevent bleeding in persons with hemophilia and an inhibitor. We rely on you to tell us, is it working or not? Now, for most non-emergency or non-life or limb-threatening bleeding episodes, that's usually enough, because usually the patients are very reliable at telling us whether something's working or not. But really, when we're talking about severe bleeding or life-threatening bleeding, we really would like to have a go-to laboratory test that tells us or predicts for us that we'll have good control of bleeding or prevention of bleeding. And for neither Novo7 or FIBO, we don't have that. So some of our colleagues around the country are working on these diligently, and hopefully we'll have something on that order soon. Okay, so with that, I'm going to close, and I'm going to turn things over to Dr. Ruth Malvani to talk about physical therapy interventions. Good night.
Thank you, Dr. Tarantino and Jennifer, for doing a great job and helping all of us understand better about inhibitors and the problems and the management that go with them. And thank you to everybody out there listening. What I'm going to do is talk with you about physical therapy interventions. And if you've been around physical therapists much, you know we have lots of recommendations. And I think what makes it easier to understand and follow those is if you know why we make the recommendations we do. Let's see. Okay, just 1 second here. Oh, there we go. Okay, objectives. So what I want to do, I've got 5 recommendations that you will often hear from physical therapists, and they are, what do we say about joint protection? We talk a lot about rehabilitation, strength and flexibility programs, assistive devices, and weight management. So I hope by the end of this you'll have a little bit better idea of why we have those recommendations. First of all, Jennifer did a nice job of introducing these to joints. A joint is 2 bones that come together, and they are the key of the musculoskeletal system. They're why we can move around, we can bend down, we can stand up, we can scratch our head. Having good joints gives us the freedom of movement and function. So as Jennifer mentioned, a joint comes together. You have typically 2 surfaces, and in this one, my little yellow arrow, we're looking at the knee joint. And you have a nice round surface of the femur, and then you have a nice concave surface of the tibia. And in a healthy knee joint, just using the knee as an example, they fit together beautifully. And the surfaces are smooth, they're coated with cartilage, and they fit together beautifully, and that gives us good function. The other thing we have to hold those bones together are ligaments, and I'm outlining that there's 4 major ligaments in the knee, and those are like duct tape. If you think of wrapping the joints with duct tape, because something strong and flexible has to hold them together. And then you have muscles, and we all know what muscles do, and our muscles have to be strong and coordinated and flexible in order to work well for us. The other thing that we have, which is good, but it also causes us some problems, is that we have a blood supply to the capsule and what we call the synovium that lines the joint, and that's kind of where we get in trouble when we have bleeding disorders. And the last thing is, all of this surface, in order to work smoothly, there is a joint fluid that I consider it the WD-40 of the joint. It oils it and it lubricates it. So Jennifer mentioned that when you have multiple bleeds, it causes some really significant problems. And this picture is a gentleman who has obviously had many, many bleeds in both elbows. His knees have tremendous problems in both ankles. And this is an x-ray of the kinds of how a joint looks when it's had many, many bleeds and can be destroyed. So we are adamant about preventing bleeds and minimizing bleeds and taking really good care of those joints. So, and you see this list: loss of motion, weakness and atrophy, impaired sensation, the feeling in your extremities, stiffness, pain, and just long-term joint disruption. And when we talk about prophylaxis and we talk about joint protection, we're saying that because every bleed counts. And so often we have questions about, well, my son is playing in a tournament, and even if he gets a bleed, we want him to play. We try to emphasize that every bleed counts, and we want to avoid or minimize every bleed and the injury that it's caused. And then with inhibitors, managing bleeds is more challenging, as Dr. Tarantino and Jennifer have pointed out. And Jennifer did a really nice job saying, and therefore there's pretty significant danger. Certain bleeds are even more dangerous. And this is a picture of obviously a little boy who's already has some pretty serious damage to his knees. General guidelines, Dr. Tarantino mentioned this. We talk a lot about the activities, the things that cause damage to a joint. Involve impacts like running down a basketball court and doing a layup and landing on one leg, twisting, strain, and then cyclic loading. And some examples of sports that we physical therapists who treat hemophilia recommend avoiding are football, rugby, ice hockey, those contact sports, as Dr. Tarantino mentioned. And we especially are concerned about any activities where the head might be injured. And again, Jennifer mentioned the really serious bleeds, the emergencies. And headers in soccer are an example of ways that people can get some head bleeds. Anything that involves riding a bicycle, for example, without a helmet, we're very concerned about activities where we protect the head and avoiding activities where there might be injury. Martial arts is a great activity until you get to the sparring part where you're actually having contact. So those are some of the examples. And what I did is list, we have a very short time with you and lots of information to share, so I've listed these references, these resources: the National Hemophilia Foundation, Hemophilia Federation of America, and World Federation of Hemophilia. You can go on their websites, which I have listed at the end of this, and get excellent information on any questions that you might have. This slide is just an example of some of the tools that we use and we have from the World Hemophilia Foundation, excellent information on exercises. National Hemophilia Foundation has information on sports and activity. HemoAware is another great resource that you get from NHF. And then there are, just numerous other opportunities to find information. Some of our older patients are looking at total joint replacements. So there's great information out there on all of these topics. And I so encourage you to be as knowledgeable as possible. So just to continue on the joint guidelines, joints are the most vulnerable during and just after bleed. So physical therapists will talk to you about we have to protect these joints in these phases. First and foremost is to use your factor replacement, but then we want you to immobilize and rest the joint because all of those tissues that we talked about are swollen. They are so much more vulnerable to bleed during this period of time. And again, it's very tempting to go out and play soccer or do the things that you would normally want to do. But if you still have swelling and the joint is hot and it appears to be inflamed and it may or may not be painful, that joint really needs to be protected. It is extremely vulnerable. And once the swelling is gone and the bleed has resolved, then what we need to do is gently rehabilitate after each bleed. Again, I have your great resources. So let's talk about rehabilitation. The second thing you'll hear from physical therapists, every bleed initiates a response that causes some, even little tiny microscopic, but some bleeding to joint surfaces. And you see the picture of this little guy with this bleed. That duct tape that I said that holds the joint together is way overstretched now because of the swelling. The muscles respond by sort of shutting down, and if you can see, there's a lot of atrophy or minimal muscle around to protect this joint, and then that also affects your ability to move and to have good coordination. Also, every muscle bleed results in some degree of damage to the muscle. So rehabilitation is a way to gently bring a person back to restoring function. And it's really needed after every bleed. Now, rehabilitation doesn't necessarily have to happen in a physical therapy clinic. You can get good information about how to rehabilitate at home. You can do home programs. You can do activities independently. And in some cases, that's certainly preferred over having your life tied to a physical therapy clinic. Again, though, joints and muscles are very vulnerable and easily re-injured, so you need the guidance of someone who understands the anatomy and physiology and how to gently, in a very balanced fashion, bring your joint back to health. It's a very delicate balancing act, and we're trying to get back your strength, your proprioception and coordination, the motion, the function, and the stability of the joint. The third topic that you'll hear us talk a lot about, which sounds contradictory, because we just said you got to be really careful with activities and certain sports you should not be in, but the paradox is that you really, all of us, with hemophilia or not, really need to be involved in fitness programs, and especially with bleeding disorders. A person with bleeding disorders needs an ongoing strength and flexibility program. And what I've found in research that I've done and that other people have done around the country is everybody can exercise and improve. Even for some of our folks who have terrible joints, there are ways that people can exercise and can improve. And multiple studies have shown the benefits of people with bleeding disorders, even people with really severe joint disease. Multiple studies have shown the advantage of that. The recommendation is that you participate in a continual fitness, strength, and flexibility lifestyle, and that you stop only when you're having a bleed and you need to recover from it. And my opinion is that if you have an elbow bleed, you can still exercise your other joints. So actually, you could always be involved in a strength and flexibility lifestyle. This is just a list of some of the benefits of fitness, strength, and flexibility. And again, this applies to everybody. Moms and dads out there, they're hearing this, sisters, brothers, people that don't have hemophilia. It applies to all of us. The benefits of exercise, there's a saying that if you took the benefits of exercise and put them into a pill form, like a multivitamin, it would be the most widely prescribed pill in the world, because it would solve so many of our preventable diseases and problems. So, and I have some sources on there for fitness and exercise for you. Okay, assistive devices. First of all, what is an assistive device? It's everything from your hair dryer to the key fob that you use to open your door, to your remote control for your television, your microwave, and I assume everybody that's involved in this tonight is on some kind of computer, an iPad, some kind of technology. So it's hard to imagine where we would be without them. And fortunately, there are some wonderful assistive devices that are available that especially help people with some physical limitations. And I'm going to talk about 3 different kinds of assistive devices that you'll hear physical therapists mention, and they have to do with mobility, braces, orthotics, supports and taping, and then activities of daily living. So mobility, this is so critical, and maybe one of the things physical therapists are most involved in is keeping people up and going. And I will say I've never met a more determined patient population, more courageous patient population than the people with hemophilia that I've worked with. And this is critically important to so many people. One of the things, basic assistive devices are walking with crutches and canes, and they help support those weakened joints and muscles. They also protect the joint because if it's vulnerable, it reduces the weight bearing. It reduces pain. People who every step they take is painful as soon as they put weight on that ankle or that knee, you can reduce that weight bearing pain, and it improves stability and balance. And one of the things we're concerned about in physical therapy is that research is showing us that a lot of our people with hemophilia, bleeding disorders, and joint disease are falling. And those falls are, really serious, a severe way of getting injured. And so we really would like to, there are times we recommend using a cane or a crutch for balance and to improve stability. When walking is no longer functional, and again, I've seen my guys have really fight to not give it up, there comes a point when it is so painful, it takes so long to get anywhere, it is so exhausting that using wheeled mobility is really a good option. It's nice that we have that option. I'll show you a couple of different types that we have in our next slide. Another thing that is a lot of people with bleeding disorders find difficult are going up and down stairs. It puts tremendous force on the joints of the lower extremity. So that's especially, that's a good option. Okay, so this picture just shows there are simple little devices like transporters. And some of these you can get for between $100 to $200. The beauty of these is some of them weigh about 14 pounds. They can be folded up like a lawn chair, thrown in the back seat, and off you go. People do need to be pushed in these transporters. But if you've got to make a quick trip to a doctor's visit or somewhere at a period of time that an individual's not walking, this is good, and they fold up and fit into a closet. So I recommend these a lot for people who aren't going to need permanent mobility. The standard wheelchair is great. It's a wonderful invention, been around for centuries. The downside is it's very heavy, and if a wife or a mom is trying to load the chair into a car, you got to have a good-sized trunk, and some of these things weigh 45 pounds and up. So they're wonderful. I'm so grateful that we have them. The weight of transporting them can be a challenge. Another option are these power chairs, and they're great. And a person can go anywhere they want. They don't have to self-propel. Sometimes a person with hemophilia has elbow problems, and trying to self-propel, pushing a chair can cause elbow and shoulder problems. So another option is a power chair. Another one that is kind of more popular and snazzier is a Segway. You're starting to see these out on the street. And for a person who has challenges walking, these things are really pretty useful. They get you where you want to go, and a lot of people are starting to like those. This picture is showing how you would load some of these heavy devices. That lady happens to be my mom loading her scooter, which is attached to a crane, and she pushes a button and it loaded it into her van. And so there are many assistive devices to help you load these devices. The stair climber is a nice option. Some people live in homes with stairs and they don't want to leave their home, but the stairs are very difficult. So installing an elevator in a home or getting the stair lift can be helpful. The last one I have on here, this is an elevated commode seat. One of the problems with having stiff joints, stiff knees and hips and ankles is getting up and down from a surface, a couch, a chair, a car, the commode can be really hard when you can't bend your knees enough to get your feet back under you and when you have weakness and pain. So there are lots of ways to elevate furniture or commodes to make it much easier to get on and off. Okay, bracing and assistive devices. We talk about using these in order to help stabilize and support your joint. They rest and protect. They reduce the weight bearing in some cases. Many people will tell you that using orthotics of some kind has helped reduce their pain by taking some of the stress off the joint or redistributing the weight bearing. They help maintain a joint position so it doesn't get worse, and in some cases, they can even help gain range of motion. Again, this is just a quick picture of there are hundreds and hundreds of different types of orthotics. This one obviously is a stronger, more stable knee brace. These are, the second picture, are shoe inserts that can redistribute forces and make walking on a painful ankle or foot so much better. Simple little knee sleeve. A lot of the guys I've worked with have told me how much it helps in terms of comfort. There are more aggressive ankle orthotics that sort of go up the back of the leg. We've got studies showing improvement in gait with those. Simple elbow sleeve, and then this is just a type of ankle strap that, again, many of my guys have said really helped. And as Dr. Tarantino said, we learn as much from you as you do from us. So the third category of assistive devices are for activities of daily living. These are the chores. These are things we do every day: housework, yard work, taking care of our homes, our computers, eating, dressing, bathing. And as people, especially as they lose strength and motion in their joints, these things become very challenging. So I just put in a couple of examples, like modifying your home with sliding shelves so that you don't have to kind of get down on your hands and knees to find out what is actually in the bottom of that cabinet. There are devices that help with limited motion with your computers and your technology. This lower left shows this is a dressing stick. It's, again, when you can't bend your knees very much, it's hard to pull up your socks, hard to get on your shoes. There are a number of devices that help with dressing. This odd-looking thing is actually a toenail clipper. Again, when you can't bend your knee and you don't have good motion in your ankle, it's hard to get down to your toenails. It's hard to get to your shoelaces to lace up your shoes and put on socks. So that's just another example. And then a lot of the guys have told me when they can't bend their elbows very much, it's hard to get to their back, it's hard to get to the top of their hair. And so there are many other types of devices for bathing and long-handled devices for brushing teeth, reachers for being able to reach over and get things. So the last thing I want to talk about is probably the least favorite subject for all of us, especially after the holidays. Thanksgiving and Christmas, we kind of cringe at the thought of talking about weight management. But the fact is that every single pound counts for all of us. And being overweight with a bleeding disorder is even more critical to control your weight, because every extra pound increases the risk for disability. Each pound puts more force on the joint, and the joints are already so vulnerable. And the excessive weight in all of us, with or without hemophilia, there's dozens and dozens of studies that show how excessive weight promotes arthritis in joints, osteoarthritis. So we need to try to keep the whole family, not just the person with bleeding disorder, in a healthy range. Now this next slide is got a lot of information on it, and this could be a whole 2-hour seminar in itself. But being overweight can lead to so many problems. And I won't go through and read all of these. But again, everything from heart disease, depression, diabetes, stroke, miscarriages, pain. I mean, we consider being overweight kind of public enemy number one in terms of what we know now about obesity, and even just being moderately overweight, the terrible price we pay for that. So how do we know all these? Multiple studies have shown, especially with hemophilia, you have more joint bleeds because you have more stress, you have more musculoskeletal problems, and then this leads to a sedentary lifestyle and getting deconditioned. It can lead to pain, depression, and an impaired function like ability to walk, ability to come to standing from sitting, going up and down stairs, energy expenditure. So with hemophilia, it's all worsened. Okay, so then here's the question that the $1 million question we all want answers to. So how do we manage it? it's a multifactorial problem, and it takes a multifactorial approach. So exercise, healthy eating, and improved fitness for the whole family are pretty significant pillars in holding up this edifice that we're trying to do to help us. And I have some very good resources for you. When I talk about exercise, I know, again, that a lot of people with bleeding disorders find it challenging to find good exercises. So there are quite a few good resources out there to discuss that. So a quick summary then from my colleagues and I. We hope that we've been able to provide you some good information. My summary of the 5 recommendations that you typically have from physical therapists, I hope you understand a little bit better why you hear many of us saying these common things over and over. And I thank you for your attention. And now we'd like to go to the questions. We're ready to take questions, and we'd like to hand it back to our moderator.
Thank you. Ladies and gentlemen, to ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen. Type your question into the text box and then click Send. If you wish to ask a question live via the phone, please press *1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, take it off mute when you are selected to ask your question.
So it looks like our first question says, why do we see inhibitors develop more often in persons with factor VIII or factor IX deficiency? Dr. Tarantino, I'll have you answer that one.
Thanks, Jennifer, and thanks for that question. That's a very good question because we see a marked difference in the inhibitors between the people with factor VIII deficiency versus factor IX. It's way more common in people with factor VIII deficiency. In fact, about 20 to 25% of persons with hemophilia A or factor VIII deficiency will develop an inhibitor at some point in their life, usually early on in life, whereas only about 2 to 5% of people with factor IX deficiency will develop an inhibitor. So we have to remember that an inhibitor is immunity against the factor VIII or factor IX that we give a person. So factor VIII and factor IX are very different molecules in the body. They help really with the common goal of making a good blood clot, but they're very different molecules. Factor VIII is a very big, complex molecule, and in general, the more big and the more complex a molecule is, the more our immune system can recognize it as foreign, because the more subtle differences there are between individuals and their factor VIII molecule. So when manufacturers make the factor VIII molecule, it's typically based on one gene and the product of one factor VIII gene. And sometimes when the person receives factor VIII and it's substantially different from the factor VIII that they would normally make, they develop immunity against it. I guess a good question to ask too is, why do 75 to 80% of people with factor VIII deficiency not develop an inhibitor? So that's a very complex question with a very complicated answer that I'm afraid we don't really have all the elements of the answer at this point. We sometimes think of our bodies as maybe tolerating foreign proteins, and tolerating meaning that our immune system just sort of gets used to it being injected into our bloodstream and sort of controls itself and doesn't develop an immune response. So that tends to happen more with factor IX than it does with factor VIII. So that's one of the reasons why we see less inhibitors to factor VIII or factor IX. It's because the factor VIII is a more complex molecule that's recognized by our immune system as a foreign protein more than factor IX is.
Thank you. We have our next question for Jennifer. If I am not sure if the pain is from arthritis or a bleed, should I infuse?
I think that's a very difficult question because it is sometimes hard to differentiate between pain from arthritis versus am I really bleeding. If you do infuse, it is not going to harm you. So sometimes it's just a matter of trial and error. If it's a common joint that you have pain in and you continue to have pain in that joint despite an infusion, then it probably is arthritic pain. If the pain goes away, then it was probably related to a bleeding episode. So that is a hard question and doesn't have a straightforward answer, but I think as you know your own body and know how you react to different things, that is easier to flesh out over time, and really having a good discussion with your treatment center as far as your joint status and where you are, and are there options to treat to help avoid bleeding or the prophylaxis that Dr. Tarantino mentioned. Those are all great discussions to have with your treatment center.
Thank you. Next question for Dr. Mulvaney. I have severe arthritis in most of my joints. How can I exercise?
Very good question. There are many, many ways to exercise, and especially for people with really severe joint damage, we have found that getting in a swimming pool, aquatic therapy, aquatic exercise, is very comfortable because the water sort of has a buoyancy, so being able to walk and to move freely in water helps. And also, you can do a great number of different kinds of strength and flexibility and balance exercises in water without stressing the joint. So you often hear us recommending that. But the other thing is there are ways that you can very gently start with exercise with your joint. Typically, a person who has joint damage needs to be much more conservative than the typical person you see walking around in the gym. You have to start conservatively, start with a small amount of weight, always err on the side of being cautious, and progress as you find that you can lift more weight and that you can do more motion. There are a number of articles out there on that topic as well, and I'd be happy to list some of those. But again, I have seen people with hemophilia with terrible joints be able to exercise in the pool or on a treadmill or different options and have tremendous benefit from it. So thank you for that question.
Okay, our next question is, are there any over-the-counter supplements that can help with joint damage? Dr. Tarantino, do you want to address that?
Right, so that's a great question too, Jennifer, thank you. The supplement question is always a difficult one because as you may know, food supplements are not regulated by the same agency that regulates our prescription and over-the-counter medication. So therefore, sometimes we really can't reliably know what's in the supplement. So at the same time, we want to recommend good things and beneficial things in the form of medications or vitamins or supplements. The supplements are sometimes not composed of what the label says, and the claims made about a supplement helping, say, joint health, for example, can't always be relied on. We do know that many of our folks with hemophilia and joint problems have taken a supplement called glucosamine, which is available in pretty much every drugstore. And as far as we know, even though no very stringent scientific studies have been done to test glucosamine, some of our folks say they feel some joint improvement with glucosamine. However, because of what I said earlier about not knowing exactly what else is in the supplement, we don't typically recommend those. We do know that there are some reports, some case study reports, that chondroitin, which is another joint health supplement, can actually cause bleeding or increase bleeding. So we tend to recommend that our folks with hemophilia steer away from chondroitin. Sometimes the supplement is a combination of glucosamine and chondroitin. So I usually tell my patients with hemophilia not to take the combination supplement because of the potential for the chondroitin element to cause or exacerbate bleeding.
Thank you. It looks like the next question, and this will be our last question, is for Dr. Mulvaney. What is the best to treat a bleed, heat or cold pads?
Well, to treat a joint, the hot or the cold is a great question. If the joint is hot and swollen and it's been a recent bleed, you don't want to use heat, because heat is not recommended with inflammation or with bleeding. After you've had your factor and you believe that the clot has formed, using ice can help decrease the inflammation. It can help decrease the pain. So right after a bleed, once you've had your clot medication, your medication to form a clot, cold is usually recommended. But for the old stiff joint that's got some arthritis and it's hard to move, heat can be very helpful. It can be helpful and it can be very comforting. So it depends on what stage the joint is in. Acute bleed, after you've had your agent, cold is recommended. For long-term arthritic joints, heat is usually what you might prefer.
Thank you.
And that was our last question. Thank you to our speakers. Your feedback is critical to us, not only in measuring the efficacy of this webinar, but also in planning of future inhibitor-related activities. Only to the degree that we have a full understanding of your thoughts and opinions will we be able to provide learning opportunities that speak to your needs. So please complete this 5-minute survey now appearing on your screen by clicking on the link. And lastly, a quick reminder to join us on Wednesday, February 11th at 7 p.m. Eastern for our next webinar, Speak Up, Learning to Advocate for Your Child. Thank you for attending, and this concludes the program.